It used to be the case that there wasn't much we could do for patients with HFpEF other than try to treat or palliate their symptoms.
The fact of the matter was, we really didn't have anything. Only in the last 5 years did we finally start having real successes of medications that work.
SGLT2 inhibitors can improve symptoms and have benefit in preventing hospitalization, as do MRAs. GLP-1 RAs can improve symptoms, and we're gaining more and more data about their benefit on outcomes, in addition to overall treatment of risk factors.
Even if they're just treated with SGLT2 inhibitors, the trials, both the DELIVER trial and EMPEROR Preserve trial, showed that the curves for survival free of cardiovascular death or heart failure hospitalization diverged at about 13 days. So we're already seeing a benefit at about 2 weeks. That's a big change, and that's, just one therapy.
The medicines that we use to treat heart failure with preserved ejection fraction, primary care clinicians are already using. They're already using it to treat diabetes, they're already using it to treat kidney disease and so forth. These are not foreign medicines. These are medicines that they're using for other things anyway that are also effective in this patient population.
There's also a lot that can be done that's non-pharmacological. That's why we really need to make a push to educate patients about diet and exercise, and monitoring and knowing their bodies. At the end of the day, the key thing to know is that the treatment of HFpEF has been revolutionized. Understanding that there's so much we can do for the patients now is critical.
We know that HFpEF interferes with quality of life, and the goal with treatment is ultimately to improve quality of life, to improve functional status, and to prevent hospitalization.
The first thing we do is start an SGLT2 inhibitor. I think that's the standard of care. We know that from multiple trials, reduction in heart failure hospitalizations. And I think that it's really important to understand that our sort of knee-jerk reaction may be to put them on a loop diuretic, like furosemide most commonly. But we want to use a HFpEF-centric approach to diuretic therapy. Take a breath in. Once you start the SGLT2 inhibitor, are they still fluid overloaded or breathless? And there, the next drug is a mineralocorticoid receptor antagonist. So spironolactone, eplerenone, finerenone, really important. If they need a loop diuretic, which often is the case, get them diuresed and then minimize the dose.
We talk about HFpEF as if it's one thing, but a number of underlying things could mean that patients will respond better to one class of medications than others. For example, SGLT2 inhibitors seem to be beneficial for all causes of HFpEF, but if your patient has diabetes, of course, it's going to be particularly beneficial. Many of our patients with diabetes also have hypertension. That's where ARBs and ACEs can be particularly useful.
If they're obese, we need to think about semaglutide or tirzepatide, the two GLP-1 receptor agonists that have been proven in that patient population.
The newer classes of medications, the MRAs, particularly non-steroidal MRAs like finerenone, may be particularly useful for our patients who have chronic kidney disease. SGLT2s are helpful there, ACE inhibitors and ARBs are helpful there, but finerenone is really the new kid on the block where not only are you going to be addressing their HFpEF incidence, but also you're going to be helping reduce the progression of their kidney disease. Breaking it down to the underlying causes and the underlying pathophysiology may be a way in for clinicians so that they understand which of the tools they can now use would work best.
I didn't know what to think when it was originally diagnosed. I was depressed. Not depressed where it was like sinking into a level that I wouldn't come out of it. It was just like, oh, this is what my future is going to be. I'm not going to live a long life. I'm not going to be able to see my grandchildren grow and get married. That was my initial reaction. Dr. Shah would comment and say, well, we want to make you feel better. That actually gave me a lot of hope that he did care and that he wasn't just dispensing medication to me. He just told me in a very clear way that I was able to understand. Without understanding your whole disease, everything that's going on, you can't make a good judgment decision. And the more that you know, the more you can help yourself.
I usually take time with patients trying to explain that what they're doing at home is going to affect their symptoms.
I think it's really important to actually help your patient start to make linkages in their lifestyle. I ate this, my blood pressure did this. I ate that, my blood sugar did that. Using these kinds of feedback mechanisms so that they can actually improve their lifestyle and avoid those things that seem to cause spikes in their blood pressure.
I think the biggest thing to stress is the monitoring. They should be monitoring weight daily. In the mornings is the best time to check that. Checking blood pressure and heart rate daily, if not twice a day. A lot of patients have evening medications, and it's helpful to know that your blood pressure prior to taking those. Those are kind of the two big things to check, but they should also kind of keep an eye on, do they have any swelling? Are they checking their legs? Are they wearing compression socks? Are they elevating their legs when they can, when they're resting, to help kind of offset that fluid? Sometimes patients just think, well, oh, if my legs aren't really swollen, I must not be retaining water. But it can be in other places. That's when checking weight can be helpful for patients, just to be more in tune with their body.
What we tell patients is if they gain more than 2 to 3 pounds in a day or two, that they need to call us because we need to adjust their diuretics. If their blood pressure, we give them targets if it's too low or too high. We're really trying to empower the patients to understand the disease and communicate with us.
HFpEF can be very confusing.
I didn't really understand what my heart problem was. I got a better understanding today of what's going on with me than when I was first diagnosed. I need to be, watching the salt, watching the sugar intake, and exercising.
A healthy diet, low salt diet, and exercise, that is a foundation for any cardiovascular problem at any time. So we want to emphasize all of those things in patients with HFpEF.
Nutritionists are incredibly good at understanding the context of a patient's life and how to actually give them good implementable recommendations about how to change their diet. But if there were just a few things that you have time for in the office visit, really focusing on salt and the foods that salt is in is incredibly important.
Being a high blood pressure patient, I'm only supposed to have 1,500 milligrams of salt per day. So I thought 1,500 milligrams of salt was a lot, but it's not. It's about a pinch like this. That's all.
For most patients, it's sort of confusing. Making sure patients know how to read the labels, they see that sodium, they know they're adding it up across the day is really important. Oftentimes, the biggest thing patients can do is not eat out as much and not eat as much processed foods.
I realize now I could use the Italian seasoning, garlic powder, onion powder, salt substitutes like Spike and Mrs. Dash. That's giving more flavor to my foods.
Within the HFpEF context, often patients are already symptomatic with any exertion, or they have functional limitations because they tend to be older or may have other comorbidities that impair their ability to get around.
When doctors would say, how much do you exercise? I would tell them, I can't. It's not that I don't want to do it. I can't do it.
Trying to figure out what is a regimen that you will be able to stick with is probably the most important. Structured exercise programs can be really helpful.
This class is all chair-based. It is a slow pace, and if you get tired and need to rest for a minute, you still get the benefit of all the other exercises that you're doing. It's not like you lose it if you can't complete it. I've had folks who come here with walkers. I've had folks who've come here in wheelchairs, and we still manage to get them through all or most of the exercises.
I use a lot of cardiac rehab. It's not covered by insurance typically for just HFpEF, but if we order phase 3 cardiac rehab, oftentimes we can find somewhere that's affordable or can find a program where they can get it.
Outside of that, I think setting minimal goals is very helpful. So if it's walking for 15 minutes a day or 30 minutes a day, if you like using Fitbits or Apple Watch to monitor your steps, having that accountability to measure and monitor and track can be really helpful and motivating for some people.
My body hurts because of the arthritis all over. So It be hurting like hell, but I tell myself, Janice, you can do this.
Before the treatment, I was very discouraged. It's much better now. I can focus on caring for my family.
My best advice to anybody about any type of disease they have, take each day as it comes. That's the only thing anybody can do.
HFpEF does not have to ruin the rest of your life.
If we diagnose it and we use the medications that we know work, prognosis is excellent.